चलो स्टूडेंट्स, लेट्स डाइव इनटू दिस। वेलकम टू टुडेज मास्टर क्लास। आज हम एक बहुत ही हाई यील्ड ऑब्स्टेटिक्स टॉपिक कवर करने वाले हैं, अबॉर्शंस एंड सर्वाइकल इनकॉम्पिटेंस। अगर आपके एग्जाम्स आने वाले हैं, वेदर इट्स योर MBBS फाइनल्स और नीट PG, you know exactly how heavily tested this is. So pay close attention, block out all distractions, क्योंकि by the end of this session आपके सारे फंडास crystal clear हो जाएंगे। Let's get started.
The agenda for today: first, definitions and classification. Then, isolated abortions, followed by recurrent pregnancy loss. After that, cervical incompetence, and finally, cerclage management. Starting off with Section 1, definitions and classification.
Okay, look at the strict cutoffs here. Examiners love tricking you on these timelines. Medically, an abortion is a pregnancy loss occurring at less than 20 weeks of gestation. But watch out for the WHO definition. They define it as any pregnancy loss with a fetal weight of less than 500 grams, which is approximately 22 weeks. Then we have intrauterine death, or IUD, which is a loss at or after 20 weeks. And, very, very importantly, the period of viability in India is officially 28 weeks. Dhyan rakhna. Mark this. It's a direct MCQ.
So how do we classify them? Broadly, abortions are either spontaneous or induced, like an MTP. Spontaneous ones can be isolated, meaning a single episode, or recurrent, meaning 3 or more. Under isolated, we have our classic clinical subtypes: threatened, inevitable, incomplete, complete, and missed. And just remember, if you add any septic foci to any of these, it instantly becomes a septic abortion. Keep this mental flowchart ready for your clinical scenario questions.
Moving to Section 2, isolated abortions. Now we're focusing on single-episode abortions. The most common cause in the first or second trimester is a chromosomal anomaly. The hierarchy goes aneuploidy, then trisomy, then monosomy, like Turner syndrome, and then trisomy 16. But here is your high-yield pearl. Trisomy 16 is the most lethal, whereas trisomy 21 is the most viable. Also, remember, advanced maternal age increases the risk. For infections, congenital syphilis follows Kasawat's law, where stillbirth is actually more characteristic than an abortion. And guys, note this down. HIV is neither abortogenic nor teratogenic. Ye examiner ka favorite trap hat, so do not fall for it. Shifting focus to Section 3, recurrent pregnancy loss.
जब पेशेंट को बार-बार अबॉर्शन होता है, the etiology completely changes. First, let's define it. The traditional definition of a recurrent abortion is 3 or more consecutive pregnancy losses at less than 20 weeks. But wait, look at the American Society of Reproductive Medicine, or ASRM, criteria. They say it's just 2 or more confirmed pregnancy losses, and that confirmation must be via histopathological examination or USG. Make sure you read the exam question carefully to see which definition they are asking for.
The crucial point here is comparing the causes: endocrine versus uterine causes. For endocrine, hypothyroidism is the most common, followed by uncontrolled diabetes, PCOS, and high prolactin. Now, uterine causes are the most common reason for second trimester or T2 abortions. Congenital uterine causes include septate, which is more common than bicorny weight. Acquired causes include cervical incompetence, fibroids, and Asherman syndrome. But listen carefully. APLD syndrome is the most common cause overall. Rhett Lewisko, absolutely crucial. And for chromosomal causes in recurrent cases, balanced translocation is number 1.
Okay, time to wake up. A patient walks into your OPD with a history of recurrent abortions. Which exact investigations should you order right now, and which ones are totally useless? Think about it for a second. Here is your answer. The ones you absolutely do: TSH for endocrine causes, a transvaginal scan, or TVS, for uterine causes, APLA antibody testing, and parental karyotyping. But what should you not do? Torch infections and VDRL for syphilis. Also, avoid routine thrombophilia testing. The examiner will confidently put torch in the options to tempt you. Usmeni fasnaibai. Eliminate it completely for recurring abortion workups.
Straight into Section 4, cervical incompetence.
This is the textbook culprit for painless second trimester losses. Diagnosis begins with the clinical history. You have spontaneous dilation of the internal os, leading to a painless T2 abortion. Usually, there's a history of 3 or more of these. In a non-pregnant female, you can diagnose it if a Hagar dilator number 8 or a Foley 16 catheter with a 1 ml water bulb passes through the cervix without any resistance. But the absolute gold standard for diagnosis? The transvaginal scan. A normal cervix is 4 to 5 centimeters. Incompetence means the length is 2.5 centimeters or less. And picture the shape change as it dilates from the inside out. It goes from a T shape to a Y to a V and finally a U. T, Y, V, U. Just imagine that cervix opening up like a funnel on the scan.
Finally, Section 5, Cerclage Management Protocol.
This can feel confusing, but don't worry, हम इसको step by step breakdown करेंगे. First, the core principles. A cervical cerclage basically involves placing sutures around the internal os. The earliest you can do this is at 12 weeks. We also use progesterone to prevent preterm labor, starting around 12 to 24 weeks and stopping at 36 weeks. Now, here is your direct, history-based indication. If a pregnant woman has a history of 2 or more T2 painless abortions, irrespective of USG findings, she straight away gets progesterone plus a cerclage at or after 12 weeks. Simple rule, straight clinical action.
But what if she only has a history of 1 T2 painless abortion, or a history of early preterm labor? This flowchart is pure gold for your exams. Step 1. You must do an ultrasound at exactly 14 weeks of gestation. Step 2. Check that cervical length. Step 3. If the length is less than 2.5 centimeters, she gets the cerclage plus progesterone. Step 4. If the length is 2.5 centimeters or more, she gets only progesterone. Sumjay, the entire decision hinges on that 14-week scan.
Sometimes a patient presents at less than 24 weeks with a dilated cervix and no prior history. This requires a rescue or emergency cerclage based on a physical exam, but there are strict prerequisites. The cervix must be less than 4 centimeters dilated. The membranes must be intact. They can be bulging into the vagina, but they must absolutely not be ruptured. And crucially, there must be no evidence of infection. These are non-negotiables before you attempt to save the pregnancy. When placing the cerclage, we have 2 main approaches. The transvaginal approach is the most common. Sutures are removed at 37 weeks, and the patient can have a normal vaginal delivery. The transabdominal approach, however, has higher technical difficulty but greater accuracy. It's usually done if the transvaginal approach fails. Here, the suture is left in place, delivery must be via a C-section or LSCS, and the sutures are only removed after the patient has completed her family. Now let's zoom in on the types of vaginal cerclage. This table guarantees exam marks, so memorize it. McDonald's cerclage uses a purse string suture in the portio vaginalis. It requires no bladder dissection but has a lower success rate and uses a non-absorbable propylene suture. With Shirodkar, however, bladder dissection is required. This is because it uses a continuous suture placed much closer to the internal os, giving it a higher success rate using Merceline tape. Wrapping up the technical procedures, let's talk about worm cerclage. This is your emergency option when the cervix is already dilated. You place 2 sutures, one in the AP direction and one in the transverse direction. It's done between 14 to 24 weeks, though RCOG guidelines say up to 28 weeks. As for the abdominal cerclage specifics, it's often done laparoscopically, sometimes involving lash surgery. Very importantly, it's performed in non-pregnant females, and pregnancy is strictly contraindicated for 3 months post-surgery to allow for proper healing.
All right, let's end with a clinical bouncer to test your understanding. If a patient presents with a single missed abortion and a TSH of 6.5, does she need a cervical cerclage in her next pregnancy? Think about the definitions, the causes, and those strict cerclage criteria we just discussed. Apply the logic. I'll leave you to figure that one out. Thank you for joining this masterclass. Keep revising, keep questioning, and go crack that